Paddy, what do you see as the strengths and the weaknesses of our current approaches for cancer treatment?
Well, our current approach to cancer treatment is based on, first of all, defining the disease based on its anatomic location, somatic phenotype, and its histology. And those approaches are ones that have stood us well over the course of the last 40 or 50 years in making real progress in developing new treatments that have cured many diseases, leukemias, lymphomas, real advances in diseases like breast cancer, indeed colon cancer and GI cancers. However, we still have a definition of disease that is largely based on pathology and somatic definition. Over that course of time, and in particular over the course of the last 15 years, we've had a technological revolution that very few would have realized even back in the early 1990s. And that revolution has allowed us now to begin to redefine disease, particularly in a genomic and genetic way, beginning to subset diseases that may be breast disease, might be colon, might be lung, and indeed leukemias in a way that we would have not dreamt possible 20 or 30 years ago. The paradigm for this in some respects has been the leukemias. Leukemias have been using molecular markers, chromosomal translocations, in a way to subset and define disease. Indeed, lymphomas very much in the same way. Whether it's low-grade lymphoma, high-grade lymphomas, have actually used molecular markers across a longer period of time to begin to stratify based on good or bad prognosis, and indeed who benefits from what type of therapy. And indeed the regimens that have been defined in those diseases have largely been developed in those stratified populations. The revolution that's now upon us is one that is beginning to do exactly the same thing in solid tumours. And the disease that stands out in that category right now is breast cancer, where we have at least 4 subsets, possibly 5 currently defined, but the reality is there probably are 20 different subsets. Based on those 4 subsets, we know that there are certain categories that probably don't need to have chemotherapy, and that there are others where the basal phenotype where indeed chemotherapy is needed, but what type of chemotherapy in that context is best. So if you have a BRCA tumor, the phenotype there would suggest that DNA damaging agents are probably best, but do you really want to be using a spindle inhibitor or taxane? In that context, do you want to start to think about PARP inhibitors? So in parallel with these genetic developments and this genetic redefinition of disease, we also now have in parallel had this explosion of new drugs which target the biology of cancer diseases. Whether that's something that targets BRAF mutations, BRAF inhibitors, whether that's something that targets epidermal growth factor pathways, PI3 kinase, MEK inhibitors, etc., etc. And so we, in parallel with redefining the disease, also have begun to develop drugs that actually are defined around a biological target. In a given clinical and genetic context, some of those biological drugs work very, very well. However, we commonly actually move them from a point of a single biologic agent to using them in conjunction with both radiotherapy and chemotherapy. And quite often that approach has not really given the added value that we might have expected. Why is that? Well, in my view, there are several reasons. First of all, we have compared these largely to standard of care, but standard of care was developed in a very different era. Secondly, those biologic agents have been more recently defined in a very focused and driven biological context, some of which has been very tightly genetically defined. And therefore, when we put that drug into a wider population that has not been as tightly defined, or where we're also introducing combination chemotherapy or radiotherapy with it, we actually change the biological milieu and indeed the patient population that we're using the drug in. So the real challenge for cancer medicine going forward is in some respects to step back from where we are today and rethink the whole element of how we do clinical trials, how we do drug development, and what we use as standard of care. So the question I will pose in that context is, do we actually believe that a 6-week survival benefit in pancreatic cancer is something that's significant in the modern age? Are we really here treating a p-value? So, or are we here to make a real difference? And so therefore, if we actually believe the latter, then my view is that we've got to begin to allow this redefinition and genetic profiling and genetic definition of disease to actually underpin how we take clinical care and drug development forward. And that poses huge challenges to us because we actually, in a lot of respects, don't know how to do that properly.
Obviously, there are many stakeholders who need to be brought along this journey. How will you engage with these stakeholders? And do you think the current modes of interaction are sufficient? Do we have to think of new ways of engaging with these different stakeholders and partners?
Yes, we do. And there are many stakeholders that need to be involved. The first thing I would say is that this can't be done everywhere. It's too complex. And so historically, where you may have been able to take a nucleoside analog or an antifolate or a platinum agent and take it into a reasonable sized cancer program, which had a good reasonable sized clinical trial program and run a clinical trial through that, and come out with very good results and benefits to patients. I think we have to go beyond that, and because other people need to be part of the team, if you like, in terms of what this is going to require to successfully deliver for patients. So what are those things? Well, they are adequate imaging facilities. Imaging, I believe, is going to be one of the key technologies that actually drives a lot of drug development forward, because we're going to need to be able to look in real time at real responses and shrinkages of tumours, either using CT, PET or related types of technology. We also are going to need molecular diagnostics, and so our pathology colleagues need to be in partnership with us involved in this process, because if you accept that the genetic redefinition of disease is going to present the stratification approaches that are relevant, then our pathology colleagues are going to be central to helping to deliver these genetic tests in real time in a way that allows patients to benefit and allows us to get on with the treatment of our patients. We also are going to need to have the bioinformatics support around all of this to allow us to apply this technology in a credible and meaningful way. And the final thing is actually the quality assurance side of things, where these assays might have been done in labs that were not necessarily GPA or CLIA approved. They now will need to be done in that setting for us to be able to drive the type of assurance that the validity of the test has actually been assured at a level that actually means that we have good patient care.
In your article, and also as we just discussed, you mentioned the role of transformational technologies. How developed do you think these technologies are, imaging, molecular diagnostics, for translation into the clinic?
We obviously have a number of examples now where this has begun to impact. I've already mentioned breast cancer, where there's a number of different molecular tests that must now be done as standard, whether that's HER2, whether it's BRCA testing. ER/PR has been there for a long time, And we also have OncoDX testing, etc. In colon cancer, more recently, we've had KRAS testing, which serendipitously has allowed us to stratify for treatment with EGFR inhibitors, and that's been an important advance going forward. We've had the BRAF story in melanoma, again, a very, very important development in melanoma. And of course, I've already mentioned the evolution of treatment of leukemias and lymphomas. So those are very strong examples that now are in the lexicon of treatment from day to day, and that in some respects give us the confidence that we should move forward in this direction. However, the vast majority of those types of developments for patients have actually come through serendipity. They haven't come through hypothesis-driven trial designs. They've come from large trials where we've gone back and asked a question retrospectively in either tissue samples or serum samples or whatever from those patients. And so going forward, we now need to move to clinical trials that actually say, right, in a BRCA negative population in breast cancer, here's the type of treatment that we think will benefit based on both preclinical and early clinical trial data, and actually then run the trial against that group of patients and in an adaptive way, so that indeed the trial may be shorter and indeed have a smaller number of patients, particularly if response rates are very, very high in that better defined population. The same thing needs to happen in lung cancer, in melanoma and other cancers going forward as well. So therefore what that means is that we must have the biostatisticians hand in glove with us, we must have the bioinformaticians, we must have our genomics colleagues, molecular pathologists working alongside clinicians. Indeed, more work needs to be done in the design of the study and the enablers around that trial than has ever been thought about before, and that therefore comes down to the fact that I believe, there will only be a limited number of centres in each country and certainly worldwide that are really going to be able to drive this type of development going forward.
Here in Belfast, part of your cancer treatment model involves the Experimental Cancer Medicine Centre. How does this work? What are its components? And could you tell us a little bit, or the listener, I suppose, more about the ECMC model in the UK?
Well, the ECMC, or Experimental Cancer Medicine model, was set up approximately 6-7 years ago. And the whole idea was to begin to build a capacity that would deliver some of the components that relate to both imaging, diagnostics, and clinical trials. Part of the drive was to help facilitate those more complex trials that needed a broad range of expertise in order to be delivered. And so that really underpins the whole experimental cancer medicine network across the UK. There are currently 14 centres across the UK in Scotland, Wales, England and Northern Ireland, and they meet together, they work together in delivery of more complex trials, particularly at phase 1 and phase 2. Different centres will have different strengths. But what it does do is allow us to deliver those trials where it may be open in 3 of the centres working together as opposed to right across the whole network, but those centres are then delivering that trial on behalf of the whole network. It also allows some centres to stand up because they have strengths in bioinformatics or sequencing, or a number, for example, Manchester is one of the big imaging centres, or others may have real strengths in molecular diagnostics, such as ICR, Belfast, and Leeds. So there are individual strengths that differentiate across that network, but they work together in terms of presenting and affecting these complex trials for patients.
So you're really getting an added value effect through bringing in from different centres their own particular expertise, but them working for a common overall aim.
Absolutely, and my own view is that no centre, no matter how big or good they are, will be able to deliver everything. or at least very, very few will be, as a single entity. We will increasingly need to work in partnership with each other to deliver the types of trials that patients actually need us to deliver on their behalf.
Northern Ireland's Comprehensive Cancer Services Programme, which is a major collaboration between Queen's University and the Northern Ireland Health and Social Care Services, was recently awarded a Queen Elizabeth II Diamond Jubilee Anniversary Prize. Could you tell us more about this programme, what it achieved, and why you were honoured in this way?
Well, yes, I was delighted that the Northern Ireland Comprehensive Cancer Programme was chosen as part of the Diamond Jubilee Anniversary Award by the Queen, and indeed the prize was presented to myself and the Vice-Chancellor in February of this year at Buckingham Palace. The reason that we were chosen, it was the only major health area that was chosen as part of, there are 20 prizes that are given every 3 years, and this being the Diamond Jubilee year, of course, it's a very special year. But the reason that it was chosen after international peer review was because it was a holistic and comprehensive program that had gone from setting up defined patient care pathways, multidisciplinary teams, underpinned by clinical research and clinical trials, in partnership created a cancer registry, now published in the 4 Continents data set, which measured progress all the way through over the course of the last 14 years. But most importantly, that whole program had delivered significantly enhanced survival for cancer patients, which is now one of the best, if not the best, within the United Kingdom. And so we have a 1.8% decrease year on year in cancer mortality, despite having a 1.1 to 1.3% increase in cancer rates in Northern Ireland. So it was an absolute honour and delight to have been chosen, recognising the quality of the programme, its impact on patients, but most importantly, it made a real statement to cancer patients in Northern Ireland that the cancer system here is a very high quality one.
Well, congratulations on that award, and thank you very much for the interview.
Thank you, Mark.